Good evening, everyone. My name is Roxanne Chabot from RBC Consultants. Welcome to another International Dermatology Education Foundation Educational Series webinar. This evening, we are going to talk about the big picture, seen, unseen, and unforeseen. As moderator this evening, we have Dr. Leon Kircik, who is the president of the International Dermatology Education Foundation, as well as clinical professor of dermatology at Icahn School of Medicine at Mount Sinai in New York, Indiana University Medical Center in Indianapolis, and medical director at Physician Skin Care, DermResearch, and Skin Sciences in Louisville, Kentucky. Our speaker this evening is Dr. Alvaro Moreira, who is Director of Peer Education for Dermatology at Novartis. We'd like to thank our supporter, Novartis, for making this educational event possible. Before we begin, a couple of logistic tips. If you're having issues hearing the webinar, you can listen to the presentation using your telephone. Just select phone call in the audio pane and the dial information will be displayed. If you're having technical issues or if you would like to submit a question to our faculty, please submit your question in the question chat pane on the right-hand side of your screen. At the end of this webinar, a survey will pop up in your browser, and it will also be emailed to you 1 to 2 days later. We greatly appreciate it if you could fill out this very short survey. Finally, within 1 to 2 days of the webinar, a certificate of attendance will be emailed to you. Again, if you want to submit your question, please submit your questions in the question chat pane on the right-hand side of your screen. And now, without further ado, I will pass the floor virtually to Dr. Kircik.
Thank you, Roxanne, and good evening, everyone. Greetings from Louisville, Kentucky, where the Kentucky Derby happens. So welcome to another WebEx of International Dermatology Education Foundation. A couple of words before we go to the program on International Dermatology Education Foundation. We are a non-profit organization. Our principal mission is to raise awareness and improve dermatology care all over the world through education, especially in underserved areas. And we are now functioning mostly in North America, US, and Canada because of the COVID. Tonight, we are very lucky. Next slide, please. We are very lucky to have Dr. Alvaro Moreira. He is a dermatologist and he is the director of the peer education for dermatology at Novartis. And he's going to tell us about the seen, unseen, and unforeseen. Thank you, Dr. Moreira. Welcome. Please go ahead.
Well, thank you very, very much for having me, Dr. Kircik. I think this is an excellent initiative. I've seen a lot of the webinars that you have put together in the past. I'm honored to be here tonight. And we will be talking about both plaque psoriasis and active psoriatic arthritis. Someone can help me, please move the slides. Doesn't look like it's possible on my end right now.
If you click in the middle, you should be able to take control.
So I think everyone already knows COSENTYX pretty much by now. It's been around since 2015, even longer if you were an investigator in one of our clinical trials. COSENTYX is approved for several different indications. We will go over a couple of them, but there are 2 new indications that are not listed on this slide, right? But today we'll be talking mostly about adult patients with moderate to severe plaque psoriasis. But COSENTYX is also approved in patients 6 years of age and older who are candidates for systemic therapy or phototherapy. Beyond that, COSENTYX is also approved for patients with active psoriatic arthritis, both adult patients and also, since the beginning of the year, children and adolescents. Now, we're not going to be covering that as a part of today's webinar, but you can reach out to a Novartis representative to learn more about that. Beyond that, COSENTYX is also approved for active ankylosing spondylitis and more recently also for adult patients with active non-radiographic axial spondyloarthritis. We will be going over important safety information throughout the presentation, but of course the main contraindication would be a previous serious hypersensitivity reaction to secukinumab, which is unusual, but we do need to be aware of that if a patient discloses that to us. Right now, we're going to be covering what we call 3 separated components of psoriatic disease. We'll be talking about the seen part of psoriasis, the unseen, and the unforeseen. And what does that even mean? Of course, the seen component of psoriatic arthritis is a reference to plaque psoriasis. Whenever I say psoriasis today, I'm talking about moderate to severe plaque psoriasis. Now, we are actually going to be discussing in detail scalp and nail psoriasis. We are not going to be discussing all of our clinical trials that have data on plaque psoriasis. We'll be focusing on that because we believe that's more relevant to you tonight. And we're going to be transitioning then to what we call the unseen component of psoriatic disease, and that is a reference to psoriatic arthritis. The unforeseen component of PSO and PSA would be the irreversible joint damage that might occur in patients with PSA, with psoriatic arthritis. Now, the presentation is called Treat the Big Picture. We want you to think of this as a comprehensive approach to a patient with psoriatic disease, both patients that have only moderate to severe plaque psoriasis or only active psoriatic arthritis, or maybe both. And we're going to be starting with the data on plaque psoriasis. 2/3 of adult patients with psoriasis actually have at least one, often more than one manifestation of the disease. And scalp and nail psoriasis are often involved. I think that we all have different experiences in our clinical practice, but what the literature says is that up to 50% of adult patients with plaque psoriasis have nail involvement, and up to 79% of patients have scalp involvement. I'm not here to talk about my experience as a dermatologist, but I think that it really depends on how quickly the patients get to you. If they wait a very long time, they will, which unfortunately still happens in many parts of the country, they will come with a more severe presentation, and that obviously affects these numbers that we are seeing here. But what I want to explain is that nail and scalp psoriasis are important because they are actually risk factors for psoriatic arthritis. Patients with nail psoriasis are 3 times more likely to develop psoriatic arthritis than patients without nail psoriasis. And patients with scalp psoriasis are 4 times more likely to develop PSA. Now, while this is important, what we must actually remember is what the American Academy of Dermatology and the NPF recommend, and that is screening all of our patients with psoriasis for psoriatic arthritis at every visit, right? So it's not like you should not be screening a patient for psoriatic arthritis if that patient does not have nail psoriasis or scalp psoriasis. The guidelines tell us to do so, and I would highly recommend reading them in case you haven't. It's a great manuscript. Now, I'm sure if you've seen this slide, if you have ever attended a Novartis webinar or a product theater, these are our pivotal clinical trials on moderate to severe plaque psoriasis. And we're showing them because this is a branded presentation. We're going to be discussing mostly secondary and exploratory endpoints, and we are required to show the primary endpoints of the clinical trials. And back in the day, several years ago, those were PASI 75 and IGA score of 0 or 1. That means skin clear or almost clear. And we see here that for both studies, for erasure and fixture, over 75% of the patients achieved PASI 75 in both clinical trials for the COSENTYX 300 milligrams dose, which is the approved dose for adult patients with moderate to severe plaque psoriasis. And about 2/3 of the patients also achieved an IGA score of 0 or 1. Now, these are representative photos. I guess it's difficult to be a dermatologist and never have seen psoriasis, but this is, as you probably have seen many times in your own practice, what a PASI 75 response and a PASI 90 response can look like. Now, what I really want to discuss today are these two clinical trials. So Novartis actually has dedicated clinical trials for nail psoriasis and for scalp psoriasis. So the data that I'm going to be presenting in the next few slides are not sub-analysis of subgroup of patients from larger clinical trials, right? These are actual, completely independent and dedicated clinical trials. The Transfigure study studied COSENTYX in both 150 milligrams and 300 milligrams in patients with nail psoriasis, and the scalp study only had two arms, one with COSENTYX 300 milligrams and another one with placebo. And the primary endpoints are different, right? But this is the design, is a very classic design, just comparing the drug to placebo. Now, I wanted to pay attention to the primary endpoints. They are marked in purple, so they are different for both clinical trials, right? You see here for the first study, for the Transfigure study, that's the study on nail psoriasis, the primary endpoint was at week 16, right? And on the other hand, for the scalp study, the primary endpoint was at week 12, and that is relevant, and I will explain why in just a minute. Now, patients who did not respond to placebo were then randomized to COSENTYX after 16 weeks or 12 weeks, respectively. So we'll start with Transfigure. These are, again, representative photos. We see at baseline the patient has not only nail psoriasis, but also plaque psoriasis here on the fingers. We see a significant improvement by week 16, and later than by week 128, that was the end of treatment for this particular clinical trial, we see a complete resolution of nail psoriasis for this patient. Now, the primary endpoint, and we can see that on the purple box to the left, was the mean % change from baseline in NAPSI score at week 16. NAPSI score is an equivalent to PASI, but for nail psoriasis. And patients on COSENTYX 300 milligrams had a mean % change from baseline of 46%, compared to only 11.7% of those on placebo, right? And again, just to point out, as we've discussed, nail psoriasis is a risk factor for the development of psoriatic arthritis. Patients with nail psoriasis are 3 times more likely to develop psoriatic arthritis. Now, here, I mean, it's difficult to see the severity of scalp psoriasis in these photos, but there is also a score for scalp psoriasis that is equivalent to PASI or to NAPSI, but just for the scalp, it's the PSSI score, and that score was 55, which is pretty high in this case. And by week 12, that was reduced to 8. I know it's very difficult to say, but just looking at the photos, right? But the primary endpoint, again, here is interesting. It's at weeks 12 and not at week 16. So, very, very early on, I would say, actually over 50%. So every other patient had an improvement of 90%, right? So that's what that means. PSSI 90 is an equivalent to PASI 90, but this is just for the scalp. And 52.9% of the patients on COSENTYX 300 milligrams achieved that endpoint, compared to only 2% of the patients on placebo, right? And this is actually what I actually like to point out, is that in this clinical trial, while it was a dedicated clinical trial for scalp psoriasis, there were actually patients that only had scalp psoriasis. So it is possible for a patient to have moderate or severe plaque psoriasis just scalp involvement, right? Because it's a large surface of the body. It really depends. But some of the patients in this particular clinical trial actually didn't have plaque psoriasis elsewhere on the body, which I think it's an interesting point. Now, we'll be going over important safety information throughout the presentation. This is not new. If you have ever seen a webinar about COSENTYX, I think the most important take-home message today is that nothing has changed. While we have new clinical trials, including, and we're not talking about those trials today, but we have more recently, COSENTYX was approved for, as I said in the beginning, children 6 years of age and older. But the important safety information for COSENTYX did not change with the addition of those clinical trials from the pediatric population, right? As you know, COSENTYX may increase the risk of infections. In clinical trials, there was a higher rate of infections with COSENTYX versus placebo. If one of your patients develops a serious infection, please discontinue COSENTYX until that infection resolves. Now, that's pretty much it. I will be, coming back to nail and scalp psoriasis, but we are going to transition now, pretty quickly to PSA, psoriatic arthritis, and this might be new if you have never seen a Novartis webinar on PSA. But the data, it's been around for a while, and I'm going to be showing long-term safety data later on. Now, as I'm sure probably all of you know, up to 41, not necessarily 41, but a large number of patients with plaque psoriasis will develop psoriatic arthritis, right? And that changes again with different patient populations. You can find different numbers in different studies, but the pretty consistent number that we've seen is around 40%. Up to 40% of the patients, of the adult patients with plaque psoriasis may have psoriatic arthritis. There are different symptoms of psoriatic arthritis. I'll be reviewing some of them later. Enthesitis, we are pointing out here, may be one of the first symptoms of PSA. And enthesitis is inflammation at sites where tendons and ligaments attach to the bone. PSA has really very, very different presentations. Some patients have axial symptoms, spine symptoms. Others have, a more peripheral presentation of the disease. Many years ago, up to 50% of patients with PSA would present with dactylitis. Dactylitis is the swelling of an entire finger or toe. Now with better access to healthcare, maybe patients are coming earlier on, or they are being referred earlier on. I don't think I've seen dactylitis in 50% of my patients who had PSA, but just overall there are different signs and symptoms, and they are important for us dermatologists to recognize. These are the two pivotal clinical trials for PSA, Future 2 and Future 5. You see they are a little bit more complicated in terms of design than the two pivotal clinical trials for moderate to severe plaque psoriasis. What we see here, again, different endpoints, week 24 for Future 2 and week 16 to for the Future 5 study. This is important when we are comparing different clinical trials. You need to pay attention to the primary endpoints. Is that the same week or not the same week? And we see here even two very similar clinical trials, both with the same drug, with this fairly similar design, have different endpoints. So we need to be mindful of that when reviewing the data. But for the first study, Future 2, patients were randomized to placebo or COSENTYX 150 milligrams or COSENTYX 300 milligrams. And placebo non-responders were then randomized to COSENTYX at week 24. When it comes to the second study, the Future 5 study, the difference there is that some patients did not receive the loading dose regimen in the beginning. So as you know, COSENTYX is a weekly injection for the first 5 weeks, from week 0 to week 4, and after that is a monthly injection. In this clinical trial, some of the patients did not receive those weekly injections from week 0 to week 4. Right, so that is the difference here. And again, patients on placebo were randomized to COSENTYX if they were placebo non-responders. In this case, that happened at week 16. Now, the primary endpoint, we are seeing that, I'm going to start there. It's the purple box to the right. And that is an ACR response, an ACR 20 response. ACR is a composite endpoint. We're not reviewing what ACR means and all that is included in that endpoint right now. But, you know, the way that I used to explain this to the patients is that it includes an improvement of 20%. Now, there is more to ACR than just that, right? But that is just an easy way to explain that to our patients. And both doses achieve that endpoint, with 63% of the patients on COSENTYX 300 milligrams achieving an ACR 20 response at week 16, and 56% of the patients on COSENTYX 150 milligrams. Now, as I said in the beginning, we always have to disclose the primary endpoints when we are presenting clinical trial data. But what I really want to point out here is another endpoint, and we're seeing that on the left side of the slide, an ACR 50 response. So an ACR 50, similarly to ACR 20, that means an improvement of at least 50% in signs and symptoms of PSA. Now, in this particular clinical trial, and this is the Future 5 clinical trial, that was the second trial that I showed on the previous slide, what we see here is a significant improvement of joint symptoms as early as week 2 for some patients. Certainly not all of the patients, but we see that in some cases, patients will experience a 50% improvement as early as week 2. So that is what we are pointing out here, right? This is an exploratory analysis, and as any exploratory analysis, we cannot really draw any statistical conclusions. We can just, look to this data from our own clinical experience perspective, right? And then we see that for both doses, it's pretty much the same response at week 16. About 40% of the patients achieved an ACR 20 response. Now, this is the other clinical trial. So we're jumping from one to another just to show different things. This is the Future 2. This is the first trial that was on that first slide. And again, the primary endpoint was ACR 20, just like with the other trial that we reviewed. And over 50% of the patients on both doses achieved that primary endpoint of an ACR 20 response at week 24. So the other trial, the primary endpoint was at week 16. Here we have the primary endpoint at week 24, hence why the numbers are different, right? We had, about 40% of the patients achieving that endpoint on the previous slide, because that was at week 16. Here we are looking into the same endpoint, but a few weeks later. But again, this is a different and separated clinical trial. But what I want to point out here is not only the ACR 20 data, but ACR 50 and ACR 70, not at week 24 or at week 16, but what actually really matters to our patients. And that is, the long-term response. It's great to have an improvement very early on. It's great that some of the patients, while, we could be talking about a small percentage, some of them do experience a very, very early improvement. But what does that look like 5 years in? And we have 80% of the patients on COSENTYX 300 milligrams achieving an ACR 20 score, over 50% of the patients achieving an ACR 50 score at 5 years, and 35% of the patients on COSENTYX 300 milligrams achieving an ACR 70 response. So, an improvement of at least 70% in signs and symptoms of PSA. And again, ACR is a composite endpoint that we're not discussing today, but I would encourage you to look into that. Over 35% of the patients achieving an ACR 70 score at 5 years. And below we see the numbers for COSENTYX 150 milligrams that I'm not going to describe in detail, because most of our patients, we as dermatologists are most likely prescribing them the approved dose for moderate to severe plaque psoriasis, and that is 300 milligrams, right? I will be reviewing the dose for PSA at the end of the presentation, right? So that's why, if you are treating active psoriatic arthritis, the dose is a little different, and I'm going to be reviewing that later. Now, this looks complicated at first, but let's try to together make this a little easier. And we have many different numbers here. Now, what I want to point out right away is that, since you all are dermatologists, and you might be confused by the first numbers that we are seeing here, and the one possible explanation for why 71% of the patients achieved PASI 90 is that this is data from the PSA clinical trial, so collected by rheumatologists. I'm not suggesting that that is the reason why the numbers are different from what we've seen in the PSO clinical trials, but just want to point out that this is data from the PSA clinical trial, so not necessarily data collected by dermatologists and their clinical trial teams, right? But in Future 5, there were a different number of exploratory endpoints. Then what we see here is the results up to 2 years in biologic naive adult patients who received COSENTYX 300 milligrams, right? So again, adult patients with active psoriatic arthritis, and these are exploratory endpoints. We already reviewed the primary endpoints a couple of slides before this. These are exploratory endpoints, again, a more long-term response 2 years in. 71% of the patients achieved a PASI 90 response. 84% of the patients had a complete resolution of their nail psoriasis. 80% a complete resolution of enthesitis. 88% a complete resolution of dactylitis. Again, enthesitis is inflammation at the sites where tendons and ligaments attach to the bone. And dactylitis is the swelling of an entire finger or toe. And we see here that over 80% of the patients achieve that in this clinical trial, did achieve that after 2 years. And as you might imagine, dactylitis is a very, very severe presentation of the disease for most patients, very uncomfortable for sure. 54% of the patients achieved an ACR 50 response. So again, an improvement of at least 50% in signs and symptoms of PSA. And here, this is actually, it's the same slide, but this is data from another clinical trial. As you might know, some patients only have axial symptoms of PSA, right? And actually, Novartis has a dedicated clinical trial on that. It's called the Maximize clinical trial. So similarly to the nail PSO clinical trial and the scalp clinical trial, were dedicated clinical trials for those forms of plaque psoriasis. This is the same thing, and this is a very interesting clinical trial. If you treat patients with axial psoriatic arthritis, I would highly recommend looking into the data from this clinical trial. At 1 year, 81% of the patients achieved what we are calling here axial relief, and that is an ASAS 20. ASAS is similarly to ACR, is a composite endpoint that includes an improvement of at least 20% in signs and symptoms, in this case of axial PSA. Now here we're back to important safety information, and we are revealing this throughout the presentation, not just in the end, because I don't want you to just not hear that this is very important. And I know that we have heard important safety information and safety data many times in the past, but if I'm being honest, I learned something new every time I review this in detail, and I think it is important for us to do this exercise together, right? Please do evaluate your patients for tuberculosis prior to starting COSENTYX. Patients with active TB should not receive COSENTYX, and patients with latent TB they should receive appropriate therapy before starting COSENTYX. Now that sometimes means, a lot of research and digging into if the patient has had appropriate therapy for TB in the past, and that is challenging. I do know that, but it is important. When it comes to inflammatory bowel disease, this is one of my favorite topics to review, and we actually have a dedicated slide just to that later on. So I'm going to be discussing that in detail. Now, before I do that, we are going to transition to the third part of today's presentation, and that is the unforeseen component of psoriatic disease. As I said in the beginning, we have divided our clinical trial data into 3 different parts. The unseen is a reference to PSA, we just reviewed that. The seen part of psoriatic disease is a reference to the data on plaque psoriasis, and now the unforeseen is our radiographic data that shows that patients on COSENTYX might have, different progression of PSA, and we'll review that together. Now, it is important to know that PSA inflammation may be tied to irreversible joint damage. So while I was saying that patients experience a complete resolution of signs and symptoms, I was talking about dactylitis, I was talking about enthesitis, back pain, but that does not mean that every single component of PSA is reversible. In fact, that is not the case. Radiographic progression of the disease may be irreversible, right? Hence why it is very important to diagnose PSA very, very early on. And again, as I've said in the beginning, I think if you just remember one thing from today's presentation, or if you are going to be explaining this to one of your residents, one of your fellows, one of your nurse practitioners, I think that is important to remember all the time, because we do tend to forget sometimes that we should be screening all of our patients with plaque psoriasis for psoriatic arthritis at every visit, right? If we do that, we will most likely be able to diagnose those patients very early on, and that is ideal for the patient in order to avoid developing what we are seeing here, irreversible joint damage. That is this radiographic progression. In one of the clinical trials that I was showing earlier, this is data from one of the PSA clinical trials, there was an exploratory analysis at week 24 with another score, MTSS. We're not going to be reviewing what that exactly means, but it's linked to the radiographic progression. And what we see here is that patients on placebo experience a lot of radiographic progression compared to patients on COSENTYX, right? If we look to the box on the left side of the slide, we see the key secondary endpoint that I'm talking about is a change from baseline in this score, MTSS, at week 24 in a mixed population, meaning patients who, some of them had been previously exposed to other biologic, to anti-TNF alpha blockers, right? Now, here what we see is another exploratory analysis. 77% of those patients had no radiographic progression at week 24, compared to 68% of the patients on placebo, right? Again, here we are reviewing exploratory analysis, and as I said earlier, we should not draw any statistical or clinical conclusions when we are reviewing exploratory endpoints, right? And there are limitations to analyzing exploratory endpoints. One of them is obviously the lack of a comparator after some time, right? What we're seeing on the right side of the slide is the long-term radiographic data, and obviously, at 2 years, there was not a single patient on placebo, so there is not an active comparator, right? But this long-term data is important when, again, explaining this drug to our patients. It is incredible to talk about the results at week 12 and week 16 and week 24, but patients do want to know what is going to happen after that, right? Especially for a condition like psoriasis, a chronic condition. and many patients have dealt with psoriasis for a number of years, some of them for a number of decades before even coming to see us. 81% of the patients in this clinical trial had no radiographic progression at 2 years. And this is, I think a significant number of patients, 191 patients that are included. So it's not a very, very small group of patients that we selected to show this data. It's not that, it's a significant number of patients. Now, COSENTYX is at the moment the #1 prescribed biologic among IL-23 and IL-17 antibodies in rheumatology, right? And this is really just to point out that our rheumatology colleagues really trust this drug for their patients with psoriatic disease. Now we're back to important safety information. In the clinical trials, there were cases of anaphylaxis and cases of urticaria. Of course, if one of your patients develops a serious allergic reaction, you should discontinue COSENTYX and initiate appropriate therapy. I think that is pretty clear to anyone who's an healthcare professional. But I like to point out that the removable cap of the COSENTYX Sensoretti pen actually contains natural rubber latex. So please be mindful of that and discuss that with your patients if they are latex sensitive, right? When it comes to vaccines, prior to initiating therapy with COSENTYX, please consider completing all age-appropriate vaccines according to the most recent guidelines. And please avoid the use of live vaccines in patients treated with COSENTYX. We're going to wrap it up today by going a little bit more in detail when it comes to the safety data. Now, this is the classic slide. If you have ever seen a Novartis presentation about this drug, COSENTYX, and obviously the active molecule is secukinumab, you have seen this before, right? The most common adverse reactions in the clinical trials were nasopharyngitis, diarrhea, upper respiratory tract infections, rhinitis. And what we are seeing on the right side of the slide is the number of patients in the clinical trials who developed infections and the number of patients who developed serious infections for both COSENTYX and placebo. About 28% of the patients on COSENTYX developed an infection, but only 0.14% of those had a serious infection. When it comes to placebo, that happened in 0.3% of the patients, right? We're not reviewing the data from the pediatric clinical trials here. I would encourage looking into that if you have patients with, if you have pediatric patients with moderate to severe plaque psoriasis. And also if you don't, sometimes it is reassuring to tell our adult patients that the drug is approved for pediatric patients as well. And I would say that while that is not the focus of today's presentation, there were no new safety signals in those clinical trials. Now, I said that we would be back to reviewing inflammatory bowel disease cases, and that's what we are going to be doing right now. I think this is an easy to understand slide, but it contains a lot of details and a lot of important information. So we're going to be reviewing this in detail, right? So this is actually an analysis with over 3,400 patients, right? And there were 3 cases of exacerbation of Crohn's disease. There were 2 cases of exacerbation of ulcerative colitis, and there were 2 cases of new onset ulcerative colitis. That is an incidence between 0.08 and 0.11 per 100 patient years, right? Now, there were no cases in patients who were receiving placebo during the 12-week placebo-controlled period. And there was another case of exacerbation of Crohn's disease reported from long-term non-controlled portions of ongoing clinical trials, right? So these are the numbers. I cannot really say much more than this, as I'm not really allowed to make any positive or negative comments. I'm simply here to present the data. But what this means to you is that you should obviously discuss this with your patients, especially if they have inflammatory bowel disease. Do screen your patients, at least, you know, by doing a medical history and family history for inflammatory bowel disease, and be mindful of that. Be mindful when making a choice to prescribe or not prescribe COSENTYX. COSENTYX has no boxed warning, and that has not changed with the newer data from the pediatric clinical trials. And when it comes to contraindications, as I said in the beginning, the only contraindication would be a previous serious hypersensitivity reaction to secukinumab. COSENTYX does not require routine lab monitoring during treatment. That does not mean that you should stop doing whatever you do for your patients in your clinic, right? It just simply means that it is not required. I'm aware that many of us have protocols in place for lab monitoring prior to starting biologic therapy, but that is not a requirement for COSENTYX. The only thing that we need to, again, be mindful of is screening our patients for tuberculosis prior to starting therapy and for inflammatory bowel disease. Now, this looks like the same slide that I just showed 1 minute ago, but this is actually the data from the PSA clinical trials. It is very similar. We have 29% of the patients on COSENTYX developing infections through week 16, compared to 25% of the patients on placebo. I'm reviewing the data from the table on the right, and 1.3% of the patients developed a serious infection compared to 0.3% of the patients on placebo. Now, what we are trying to explain here is that you can have confidence in the consistent safety profile of COSENTYX across indications, right? So I would encourage, if you have time and interest, to look into the different clinical trials across indications, active ankylosing spondylitis, the pediatric clinical trials, both for moderate to severe plaque psoriasis and active psoriatic arthritis, and you will see that the adverse reactions are pretty much mimic one another when we are looking at different COSENTYX clinical trials, which I believe is very reassuring. Now, when it comes to the adult COSENTYX dosing, again, this is different for pediatric patients, so I would encourage you to review that as well. For adult patients with moderate to severe plaque psoriasis, the dose, as all of you know, is 300 milligrams every week from week 0 to week 4, and then every 4 weeks or every month. For patients with active psoriatic arthritis with concomitant moderate to severe psoriasis, the recommended dose is the same, but in some cases, a lower dose of 150 milligrams may be acceptable, right? Now, for adult patients with active psoriatic arthritis, but without concomitant moderate to severe psoriasis, the recommended dose is 150 milligrams. But if your patient continues to have symptoms, you can actually escalate that to 300 milligrams and or add MTX. This is relevant, especially for those of us who maybe don't have the privilege of referring all of our patients to a rheumatologist, and we do end up treating active PSA in patients that have only a mild presentation of plaque psoriasis, right? So in those cases, if you were to prescribe COSENTYX, obviously the indication for that would not be the mild plaque psoriasis, but the active psoriatic arthritis, right? So these are little details that end up making a difference in our day-to-day work. Now, the COSENTYX sensor pen has been around for quite some time. What I like to point out here is that more than 90% of the patients report no pain or reaction during or after the injection, right? So that is important. Nearly 9 out of 10 patients report being satisfied or very satisfied with the self-injection. So we are pretty much done today. We have over 14 years of clinical evidence. COSENTYX was approved, as I said in the beginning, in 2015, but there were obviously many years of clinical trials. Over 200,000 patients have been prescribed COSENTYX in the US alone. That means over 2 million prescriptions for adult patients. And there are strong patient support programs that are here to assist appropriate patients start and stay on COSENTYX. If you do need more information about these programs, do not hesitate and reach out to one of our Novartis associates at any time. So together today, we have reviewed what I know it is a lot of data. I'd be more than happy if you remember one little detail from today's presentation, right? Maybe the most important thing for you in your own practice. I don't know what that is, but you know, right? So we've reviewed different things. Nail and scalp psoriasis. Again, COSENTYX has dedicated clinical trials on that. Those were the primary endpoints of those two trials. We're not talking about a sub-analysis of a very small number of patients. When it comes to PSA, I've showed that COSENTYX actually helps across all of the signs and symptoms of PSA, from dactylitis, enthesitis, axial PSA, nails and skin, which are also part of the spectrum of PSA. And when it comes to Unforeseen, we've seen that COSENTYX actually stops radiographic progression compared to placebo, right? In patients who have active psoriatic arthritis. So COSENTYX is a comprehensive treatment for adult patients with moderate to severe psoriasis and active psoriatic arthritis. I am more than happy to take any questions you might have tonight. And you can also reach out to me or any one of my colleagues separately and after today's program. It was my pleasure being here with you tonight. Thank you for listening to me.
So I believe we have some time for questions, Dr. Kircik.
Thank you so much, Dr. Moreira. That was actually a lot of good information. Honestly, I wasn't familiar with most of the psoriatic arthritis information, so thank you for that. We have a couple of questions. One is asking about the indications for the pediatric indications, psoriasis and psoriatic arthritis. Can you let us know a little bit about that, if possible?
Yes. So last summer, COSENTYX was approved for children and adolescents with moderate to severe plaque psoriasis. So we're talking about children that are 6 years of age or older, right? There were two clinical trials showing, a safety profile that pretty much mimics the one that we just saw in the adult clinical trials, and very interesting numbers when it comes to our efficacy data. I would encourage looking into that. And now, more recently, since the beginning of this year, COSENTYX was also approved for children and adolescents with different symptoms of active psoriatic arthritis. So if you do have patients with either moderate to severe plaque psoriasis, children and adolescents, or children and adolescents with mild psoriasis but who might have active psoriatic arthritis, you can in fact consider COSENTYX as a therapy option for those patients.
Alvaro, what's the age down to 6 as well for psoriatic arthritis?
I believe it's even it's even less than that. For some
Wow.
patients, COSENTYX might be appropriate if they are as young as 2 years old.
Interesting. Thank you so much. That's really valuable information because we don't have much for pediatrics, right? So that's good to know. The other question comes up, which is actually really interesting, about the scalp psoriasis data. And is that on label, or are there any other biologics with scalp data on their label? I know we do the studies, we know the data, but is there anything that's on the label itself?
So that is a great question. I cannot talk, about other drugs and our competitors. I in fact, I just don't know enough about that. But when it comes to the COSENTYX label, the label might be updated soon. But at the moment, you would have to have a patient with moderate to severe plaque psoriasis. Scalp psoriasis in and by itself wouldn't necessarily be enough, but as I pointed out, there were patients in our scalp clinical trial who only had scalp psoriasis, but that was enough for them to have what we call a moderate to severe presentation of their plaque psoriasis.
Perfect. Also, you did mention a little bit about the vaccines, and we know from the label that it is contraindicated to give any live vaccine. But at this day and age with the pandemic, COVID vaccines are always important. So can you tell us a little bit what's the perception, what's the deal with the COVID vaccines?
Of course, it is an important question, right? So the Pfizer and the BioNTech vaccine and the Moderna vaccine are both mRNA-based vaccines. So that means they are non-live vaccines, right? To the best of my knowledge, there are no live COVID-19 vaccines approved or in phase 3 clinical trials, right? So we would, obviously ask patients to make those decisions with their own providers. We are certainly not here to give that guidance at an individual level. But what I said about patients being able to receive vaccines, especially non-live vaccines, applies to the COVID-19 vaccines. And those are, in fact, non-live vaccines. So it would be appropriate for patients to receive those vaccines. And it's actually, as we all know, recommended by several dermatology societies, right? So there are both in the US and international very clear guidelines that show that say that patients with psoriasis, especially patients who receive biologic therapy, should receive not only vaccines but also the third dose and, when appropriate, the fourth dose.
Perfect. Now, do we have any data with COSENTYX that shows about immune response with vaccination? Not necessarily COVID vaccine, but for any other vaccine, I'm asking.
It is an excellent question. Because this is a branded presentation, I can only talk about data from Novartis clinical trials, and that was not studied in as a clinical trial sponsored by or initiated by Novartis, right? There might be data on that, not exclusively to COSENTYX, or not initiated, or not from a clinical trial initiated by the company. When it comes to what we can say today is that Novartis don't have data on that, as that was not studied in one of our clinical trials.
Okay. And finally, we're almost getting there at the top of the hour. There's one more question. And, it's very actually pertinent to real life. We have patients, they lose their insurance, they get sick, basically they stop the drug. It happens all the time. They move, they go to another job, they stop the drug. Now the question becomes, and we always had some bad experiences in the past with some old biologics, first generation biologics. What happens when they stop the COSENTYX? When they start back on it, do they get the same efficacy, or they don't respond anymore? Did they develop already some kind of immunogenicity? And I know you have some trials, I think, with randomized withdrawal. Maybe can you comment, if possible, on those?
It is an excellent question and actually a very, very important one. That is not a part of the COSENTYX label. Therefore, I cannot talk about that, but their data on that does in fact exist, right? So for the people listening in today, you can certainly find that information. If you reach out to a Novartis associate from our medical team, they will be able to discuss that with you, because it's a commercial presentation and that aspect is not a part of the COSENTYX label. I cannot really talk about that, but that data in fact does exist.
Perfect. So we're almost 7 o'clock. I thank you so much for a great presentation. I thank our sponsor tonight, Novartis, and thank our audience. So this concludes the Novartis supported program, and also have a good night. And we'll see you next Tuesday at another great webinar with with antibiotic resistance and the role of antibiotics in acne. Thank you very much. Have a good evening, everyone. Bye-bye.
Good night, everybody.
Thank you for having me.
Thank you. I cannot even turn it off.
Me neither. I mean,
I don't know how to do it.
Yeah.
Alvaro, you're younger than me. You should be a little bit more technologically advanced.
Oh my, I am 11, 12 times worse than you. I am the worst when it comes to technology.
I thought I was really bad. I cannot even turn off the damn thing. Look at this. You and I stuck.
It was great seeing you. I hope to see you again very soon.
I hope I'll see you in Montauk. One weekend. Once I figure out the weekends, I'm not there yet, but seriously. Or you know what? You work from home. Take your computer, come during the week. It's even nicer during the week.
I do work from home, and I can do that. Absolutely.
And you know what? I paid $900 2 years ago, because with the regular internet, I couldn't do any of my Zoom. You know, because during the whole summer I was at home and doing Zooms. That's how I made a living. And you couldn't do it. Not only me, all the Wall Street people, Monday morning 8 a.m. because everybody was hiding out there. The internet was so busy. Finally, my wife got the the internet guy, some IT guy,
Yeah.
and I have something